Alrighty, I'm gonna give it a few more minutes to let everybody get in here. And if you were here yesterday, and even if you just like were here for like a little bit, if you would go ahead and put your name and your T2HSC email address on that that Google Doc Excel sheet that I have, if you haven't done so already, I'm supposed to like take some attendance to show how many people like utilize the resources or whatever. So if y'all would do that, I would super appreciate that. And I'm about to make one real quick for today's session. So then if you're here today, if you would, when I put that up, if you wouldn't mind putting your stuff on that as well. I'm not muted or anything, am I? No, you're okay, cool, cool, cool. Okay, I just sent the link for, sorry, I know that's a lot of sitting there with me staring at the computer, sorry. I just sent the link for today's, so if y'all wouldn't mind filling that out for me, please. Let me go do one. Is that fan noise in the background? Is that making a lot of noise on y'all's end, or can y'all still hear me fine with that fan?
I can still hear you.
I can hear you fine.
Anybody?
We can hear you fine.
I didn't hear the question.
The fan in this room doesn't work. It's kind of, yeah, I'm at my cousin's house and it's confusing, but okay. All right. Okay. All right, so let me go ahead. Okay, perfect. Thanks for I see they're applying the group thing. All right, let me get my screen share going. All right, is that full screen for y'all?
Yes.
Yeah, I can't, let's see.
Yes.
Yeah, it is.
Yeah, it is.
Okay, sorry, I realized I had my volume muted. That's why I couldn't hear anybody. So what, you said yes, y'all can see that?
Yes.
Yes.
Okay, cool. Thanks, awesome. Okay. Okay, cool. All right, and I'm recording again today. So if you want a copy of today's or yesterday's recording, email me personally and I'll send it to you. I'm not going to post that to the Facebook page, but I will post the slides to the Facebook page, okay? Okay. Awesome. All right, so we talked yesterday about the, we'll go ahead and get started. I don't think there's anybody else trying to get into the thing, so we'll go. All right. So it must have been a decent job yesterday because there's like 39 of you back, so that's awesome. Okay, so, so yesterday we talked about the cell wall synthesis inhibitors, and we talked about the disruptors of the membrane. And so today we'll go over the remaining three groups, the inhibitors of protein synthesis, the antimetabolites, which for the purposes of our test are just really going to be antifolates, and then the inhibitors of DNA. And so a lot of the ones that we go over today are going to be they're like less preferable drugs. They're a little bit more dirty, but some of them have some particular uses that will be beneficial. So starting with the protein synthesis inhibitors, this will be the biggest portion. Excuse me. So with our protein synthesis inhibitors, so we're going to have just a quick review. I'm sure all of you know, I'm not trying to insult your intelligence. I'm sure all of you know how ribosomes work, but just as a reminder, you have your two subunits, right? You have your 50S subunit, which is the bigger one, and you have your 30S subunit, which is a smaller one, and together those make a 70S subunit. And so protein synthesis inhibitors can act on either one of those subunits, and there'll be a specific way that they act on these. So in addition to knowing which subunit they act on, I would suggest that you know at least a general idea of what it is exactly that they're doing. Are they inhibiting peptide bond formation? Are they inhibiting translocation? Are they inhibiting tRNA access? Because that depth of MOA is fair game for the test. And so somebody tell me why are we able to use protein synthesis inhibitors? Why do they not cause problems for our protein synthesis?
We have different ribosome subunits.
Exactly. So our ribosomes are bigger. They look different. Ours are an 80S. Bacteria are a 70S, even though it's 30 and 50. Their Svedbergs aren't additive. So 30 plus 50 makes 70. So anyways, but yes, so ours look different, so they don't bind. In addition, okay, well, so, but there is a certain organelle in our cells that could potentially be affected by protein synthesis inhibitors. And which organelle is that?
Mitochondria.
Mitochondria, right. They have a bacteria-like 70S ribosome. So, but for most of our protein synthesis inhibitors, this isn't going to be a huge deal because a lot of them will have, they have to gain access into the cell. Remember, cell wall synthesis inhibitors, they could just kind of, you know, bebop right up to the cell wall and exert their action, but these are actually going to have to get inside the cell. So for most protein synthesis inhibitors, they will need a certain, a particular transmembrane protein in order to get into the cell, and a lot of these transmembrane proteins are only going to be found on bacterial cells and not on our cells. So that's why most of the time our mitochondria won't be affected. There is one particular drug though that will affect the mitochondria pretty badly. Which of the protein synthesis inhibitors is that drug going to be?
Is that chloramphenicol?
Yeah, chloramphenicol. Chloramphenicol is a bad drug. By and large, icky, bad. Don't give it unless that's like the only way that things can be treated. Yeah. Okay. Most of the protein synthesis inhibitors are going to be bacteriostatic. That's the opposite of all the drugs we talked about yesterday, right? Those were all bactericidal. Aminoglycosides, though, will be bactericidal. The quinapristine dalforpristin will be bactericidal. And then the chloramphenicol will just kind of do whatever the hell it wants to do. It'll sometimes be static, sometimes be stidal. It depends on the bug that we're talking about. Let's see. Macroleides and the quinapristine dalforpristin will have hepatic excretion. So that's a bit unusual. Most drugs that we're going to talk about are going to be kidneys. And so your tetracyclines, those are going to be kind of used mostly for gram negatives, but there is some gram positive uses. Aminoglycosides, those are also bad drugs. They used to be drugs we use a lot, but now they're just going to be mostly for either resistant or life-threatening gram-negative infections. Otherwise, you're not going to really want to give them. Macroleides, those are going to be primarily gram-positive and intracellular, which is going to be very helpful because intracellular drugs or intracellular bugs are going to need drugs that can accumulate within macrophages or other phagocytic cells in order to fight them off. Let's see, chloramphenicol and lincosamides, their beneficial use is primarily going to be with anaerobes. Anaerobes can prove pretty hard to treat a lot of times. And so those are going to be useful there. And then quinapristine, dalforpristin, and linezolid are mainly going to be resistant gram-positive drugs right there. And most of these are not really going to be given in pregnancy. There's a few that can, and we'll talk about those. But by and large, these are dirtier drugs. Okay, so we'll start talking about them now. All right, so tetracyclines. We'll go with those first. So which subunit are these going to inhibit?
The 30S?
The 30S, yes. So the way I set this up, I have in white the 30S, and then I have, forget what color I switched to. I think maybe I switched to black for the 50S. But there's only two that are 30S, and those are going to be, you're exactly right, tetracyclines and aminoglycosides. Everything else will be 50S. So how exactly do the tetracyclines work? So they inhibit the 30S. What exactly do they do?
They bind to site A, right? So they block the aminoacetyl whateverase.
Yes, ma'am. Yes, ma'am. They prevent the transfer RNA from getting in. They block its access. Very good. There's that thing about the transporters you don't really need. That's not going to be tested. That's just for your own. Sometimes if you know what's going on, you can remember the big things better, but that's not going to be tested. Yes, so 30S, they block the access of the tRNA. So our tetracycline is going to be bactericidal or static.
Static.
That's right. And so the way they have these, they have 3 classes. They have your short acting, intermediate acting, and long acting. And it's fairly easy to remember which one's which. So tetracycline, the one that bears the name of the group, is going to be your short acting. Your intermediate acting, does anybody know which one that's going to be? No? Okay, so that one's going to be your demiclocycline. And the way I remember that is because, so you know, in Greek mythology, you have like demigods that are like half human, half god. So demi, it's kind of like half and half. It's in between. Makes sense in my mind. And then you have your everything else that you need to know for the test will be long acting. And all of your tetracyclines can be given orally, with the exception of your long acting ones can also be given IV for the most part if you need to. But by and large, oral, and then also IV for your long acting if you need it that way. All right, adverse effects. What is the big brouhaha about tetracyclines?
It gets into the bone.
They do. And so particularly what is the, I guess at the molecular level, what's going on? Why are they affecting bone and other calcified tissues?
With metal cations?
Say again?
With metal cations? Or is it because they're just calcifying?
Yeah, you're right. So they're going to chelate divalent and trivalent cations. So a lot of those are going to be metals, but anything that has a +2 or +3 charge on it, they're going to be able to bind with. And it becomes important for several reasons. It becomes important, as you said, for the calcified tissues like bone and teeth. So it's going to bind to the calcium there. It's going to interrupt the structure of your hydroxyapatite that you have going on in your bones. And so it'll stunt bone growth. It'll give you, it'll give you weak bones and shorter bones. And then also in your teeth, it'll make your teeth weaker. And it'll also give you discoloration, streaks of discoloration in them, kind of like looks like how fluoride would do your teeth. And so for these reasons, we're not going to want to give it to pregnant women. We're not going to want to give it to lactating women because it actually passes into the breast milk. And we're not going to want to give it within the first 8 years of life. Why would we not want to give it within the first 8 years of life right there?
They're still growing.
Yeah, you're still growing, so your bones are still trying to develop and grow. So that's one reason. Also, so deciduous teeth, the ones that fall out like when you're a little kid, those are going to be starting to form in pregnancy, early childhood, but then your permanent teeth are going to be formed in your early childhood. So we don't want to affect your deciduous or your permanent teeth there. All right, so besides the calcified tissue effects, why else is it important that they're going to bind with divalent, trivalent cations?
It depends on how you can take them. Like you can't take them with milk.
Exactly. So you can't take them with dairy products because those are going to have calcium, a divalent cation in them. And when these are bound to the divalent and trivalent cations, when they're chelated, they're not going to be able to be absorbed. And so that's important because we can administer most of these PO, and so they have to get absorbed somehow, and they won't do that if they're chelated. Besides dairy products, what else, thinking medicine-wise, would we not be able to administer at the exact same time as tetracyclines?
Iron.
Iron supplements, right? So any kind of +2 or +3 supplements, so iron, zinc, those types of things. What else?
Antacids.
Antacids, yes. So antacids are primarily, a lot of those are going to be magnesium sulfate, aluminum sulfate. So you're not going to want to give those because those have a +2, +3 charge respectively. And then there's one more.
Birth control?
Related. Sorry, what?
Birth control?
So that you're right, though this will interfere with birth control, but it doesn't have to do with the chelating properties. That has to do with effects on estrogen, which we'll pull up in a minute. So you're right. But what other what other drug is going to have chelating issues? What other drug is going to have a +2 or +3 cation in it?
Vitamin C.
So vitamin C would have, that's going to be a bit bigger molecule, and it's just going to have an overall +1. So I haven't heard of any issues of taking it with vitamin C per se. But so Pepto-Bismol is bismuth subsalicylate, and the bismuth there will actually bind with the tetracyclines as well. So you don't want to give any of those. You can still give them to you can still have your patient take them, but they just can't, they have to take them, not at the same time of day. And so I want to say we might have had a question about like some type of administration issue with that. So just important to kind of keep in mind. What is another adverse effect of tetracyclines?
Photosensitivity or toxicity.
Yeah, so some minor hypersensitivity issues like that. You're correct. That's not my next bullet. So, but I will pull it up in a bit. You didn't read my mind correctly, unfortunately. These do have a pretty broad spectrum of action. So what might be an issue with that broad spectrum?
C. diff infection.
Yeah, so we can get super infections, and not just with C. diff. It can be yeast, it can be staph. You can get all sorts of fun super infections. So, but yes, you're exactly right. Then also he mentions this thing about this hepatotoxicity that can happen in pregnant women with a kidney infection, and it can be fatal. It's kind of a moot point because you shouldn't be giving these drugs in pregnancy anyways because of the chelating effect on calcified tissue. So I would not worry about this right there. Don't really worry about that too much. Then I think it was Joy, you also mentioned about the affecting estrogen levels, which will decrease the efficacy of oral contraceptives, and you're exactly right. And this is even more so an issue because these drugs are teratogenic in the baby with the calcified tissue effect. So if your oral contraceptives aren't working as well and you do get pregnant, the baby would be at risk for having some issues there with its bone. All right, more adverse effects. You brought up, Bailey, you brought up the point about the hypersensitivity type issues, so the phototoxicity there, and you're exactly right. Minocycline is going to be special for two different reasons. One of those reasons has to do with an adverse effect. Does anybody know what the adverse effect there is?
Phototoxicity?
Is it hearing problems?
Yeah, so some vestibular disturbances. I think that might be a little nitpicky to test you on, but there it is just in case. What is the other reason? I'm not going to pull it up quite yet. I'll pull it up further down on my slide. But what's the other reason that minocycline is special? Not necessarily has anything to do with an adverse effect.
It can go into the CSF.
Yeah, exactly. It can go into the CSF. And the way I remember that is because minocycline goes into your mind. I don't know if that helps you or not. So then pseudotuber cerebri is another thing that you can get. It's kind of like this weird kind of entity. You'll learn more about it in the INS block. They won't test you on this, but if you're wondering, pseudotumor cerebri is this basically you get increased intracranial pressures without any evident cause. So there's no dilation of the ventricles, there's no mass effect going on, you just have this increased pressure for no apparent reason. It can happen sometimes with pregnancy with nothing to do with tetracyclines, but that they're not going to test you on that. Also Fanconi syndrome that you'll learn about in your SD1 block. It's a disease of the proximal tubules. It has to do with in your kidney. It has to do with inability to reabsorb things. There's also a genetic form of it that he won't test you on that either. Don't worry about that. Okay, so the last important adverse effect. So one of these drugs can be indicated for use outside of antibiotic therapy? Which one of these is the drug?
Demi.
Yep, the demiclocycline. And what kind of acting drug is demiclocycline?
Intermediate
Mediate.
acting.
Intermediate, yep, because of the demigod thing. So yeah, so demiclocycline it causes nephrogenic diabetes insipidus. And so just a reminder of what that is. That's so you get ADH production, right, by your posterior pituitary gland. And so normally it would go and it would tell your kidneys to reabsorb more water. And so in diabetes insipidus, for some reason, there is something along that axis that is preventing that from happening. If it's neurogenic, it could be the ADH isn't being produced. If it's nephrogenic, your kidneys aren't recognizing it for some reason. So because it produces this nephrogenic diabetes insipidus, what use might it find?
Syndrome of inappropriate ADH secretion.
Yes, exactly. And for bonus points, do you know what that would be associated with? This isn't going to be on your test, but
Cushing's disease.
Cushing's disease is more cortisol, so that would be more of that. That'd be you could still have some some electrolyte disturbances, but not so much the SIADH. Not really.
Is it the oat cell carcinoma?
Yeah, the small cell lung carcinoma. That's right. Yeah, that's those cells will actually start producing ADH ectopically, and you get this euvolemic hyponatremia. You don't need to know any of that right now. That's just bonus points. But I'll stick to what you need to know. Sorry. So we said that none of these, or we said that only one of these penetrates the blood-brain barrier. And which one was that?
Minocycline.
Minocycline. And we said that's because minocycline penetrates your mind. Okay. So how are these going to be excreted?
Kidney.
Yep, by the kidney, except for one. And which one is that?
Doxycycline?
Doxycycline, right? And that's kind of we kind of had a similar situation with our penicillins. All of them were excreted by the kidney, except for which one?
Naphthalene.
Naphthalene. Yeah, very good. Okay, so spectrum of activity with tetracyclines, they kind of have a fairly broad spectrum. They mainly are going to be active against gram-negatives. That's pretty much where they're going to find their use. But we do have a few gram-positive indications. Does anybody know what those are? One of them technically, I guess, really isn't a gram-positive per se, but we can throw it in that group.
Anthrax and mycoplasma?
Yep, exactly. Very good. And so as far as gram-negative infections, so we can treat a lot of things with those. Bacillary infections, what that means is just basically anything that's caused by a gram-negative rod. So things like traveler's diarrhea, which would be caused by what? Just the general bug.
E. coli?
E. coli, yep, E. coli causes traveler's diarrhea. Remember, there's all those different, like EPEC, EHEC, all those different things. Yeah, anyways. So E. coli, that would be one. Things like tularemia, what kind of exposure would you expect in someone who developed tularemia?
Is that rabbit?
Rabbits. Also things like, let's see, cholera, brucellosis, all these things are examples of bacillary infections. Okay, so the chlamydia and the rickettsia, those are special because could we treat any of those with our, particularly with our beta-lactams, but really with any of our inhibitors of cell wall synthesis?
No,
No, and why not?
because they don't have a true cell wall.
Yeah, they're cell wall deficient. Yeah, so they have a cell wall, but it's wonky. And then just some bonus review, since we're here, we might as well review it. What are some diseases that chlamydia can cause? The chlamydia genus, what are some diseases it can cause? Obviously an STD, that's probably the most famous one, but what are some other things?
Pneumonia.
Yeah, pneumonia. And what do we call that? What particular type of pneumonia?
Walking
Atypical.
or atypical?
Yes. Okay. Yes, you're not wrong. So, but what is the bug, I guess, that causes it?
Pneumonia.
What's the name?
Pneumoniae. Or
Uh,
the chylophilia or whatever.
So,
The parrot one.
yeah, so the psittacosis. Sorry, I was trying to make you read my mind. So the psittacosis was what I was referring to. And you're right, you get that from, there's going to be some kind of bird, particularly some kind of exotic bird, parakeet exposure on that one. What's another disease that chlamydia can cause?
Blindness?
Yes, and where would we see blindness in particularly? What population? What age group?
Adults.
So adults can get it, but particularly where is it going to be a big problem? We're going to prophylax it in every person who is this age.
Neonates.
Neonates, there we go. And we call that trachoma. That's when it's in a neonate, we call that trachoma. And so every baby born in the United States is going to get prophylaxed for trachoma. And we'll actually talk about that in a few other slides, so I won't repeat it here. But yeah, trachoma. And there's one more disease that chlamydia causes. It's another type of STD. Not so common in the U.S.
Lymphogranuloma venereum?
Yes. And so where are we primarily going to see that disease?
Well, that one I know is in other countries like Africa, Asia, and South America. Is that one the one that's like men particularly too, or no? That's a different one.
I don't know about the men part. I don't know if you're right or wrong. I can't remember about that. I apologize. But you are right.
No, I'm wrong. I'm wrong on that one.
Okay. But you are right in that it is in the developing countries. And then if you see it in America, though, what are you more than likely going to want to do a workup for if you see it in someone who is in America, not someone who moved here from a developing country?
Colon cancer?
Huh? Say again? I just couldn't hear you.
Is that the colon cancer one?
No, that's not the colon cancer. What you're thinking about, a certain type of endocarditis, the S. bovis, the group D strep. No, it's going to be, if you see someone in the United States who has lymphogranuloma venereum, you're going to want to do a complete immunological workup because you only see that in HIV positive individuals in the United States, by and large. Okay, and then with the rickettsial species, what are some diseases that rickettsial things can cause?
Lyme disease.
Not Lyme disease. Lyme disease is actually caused, that one's really confusing because rickettsial diseases are primarily transmitted by some kind of arthropod vector, right? And so is Lyme disease. It's transmitted by the deer tick. But Lyme disease is actually caused, what's the causative agent of Lyme disease? Anybody?
Borrelia.
Yeah, Borrelia burgdorferi. So that one, it's actually a spirochete, but it's really similar to rickettsia, so that one can be easily confused. But Lyme disease is a spirochete. Any other guess?
Rocky Mountain spotted fever.
Yep, Rocky Mountain spotted fever is the big one. Typhus is going to be another one. Ehrlichiosis, Q fever, all those things are rickettsia. Okay, I think we'll go back to drugs. Okay, so then what is the last kind of area that, I'll just put it up. So it's also gram-negative. Spirochetes are going to be the third area that tetracyclines are going to cover. And so there's your Lyme disease right there, Borrelia burgdorferi. And then H. pylori, where does that infect?
Your stomach.
Yep, your stomach. Huh?
Does it also affect the duodenum?
So they're not really going to live in the duodenum per se, but you will get duodenal ulcers from this. That's actually the primary place that you'll get the ulcers because you because you're altering the pH environment and so of the stomach, and so as it comes into the duodenum, that's where it's going to kind of exert its effect. You can get gastric ulcers as well, but duodenal is primarily where you're going to see those ulcers. Although the bacteria are not really primarily going to live in the duodenum, if that makes sense. And so for H. pylori, this will be part of the triple therapy for H. pylori, which is actually now mostly quadruple therapy because all of the resistance and is pretty widespread and whatnot. But yeah, just remember H. pylori. And then also amoebas, but that's next unit, so you don't have to worry about that for this unit. Okay, so then a few other uses, they're just kind of that are important. Use in teenagers, you're going to use this in teenagers a lot to treat what disease?
Acne.
Acne, yeah. So that they think that acne is caused by Propionibacterium, and so it's going to be able to treat that. There's your Bacillary infections with a few examples of those, and then it's also can be used as a backup drug for syphilis. Although the drug of choice for syphilis would be what?
Penicillin.
Penicillin.
Penicillin with what?
G.
That is right. That is right. Penicillin G. Okay. That's everything for that. All right. So moving on to the
Quick question.
Yes, ma'am.
On that slide, you said that you said rickettsia caused ehrlichiosis and Q fever. It does?
Thought so. Am I incorrect on that?
I thought it was Coxiella that caused Q fever and
Coxiella burnetii.
yes, and then Ehrlichia chaffinus that caused ehrlichiosis.
Yeah, you are right. I'm sorry, I misspoke on
Okay,
that.
no, that's fine. I just wanted to make sure that I didn't miss
No, I'm
that.
glad you said something. I apologize. Yeah, if I ever say something that that sounds wrong, tell me and let me correct it or whatnot. Yes, that's correct. Yes, thanks for bringing that up. Sorry about that. But the other two, the other things I mentioned, I believe, were correct. Okay. Yep, you're right. All right, aminoglycosides. So what are those going to act on?
The 30S subunit.
Yep, the 30S. And so this time, what are they going to do? What's their mechanism of action going to be here?
They stop it from exiting.
Come again?
They stop it from exiting the channel.
They do a lot of things. By and large, what they're going to do is they're going to cause misreading of the genetic code. And because they misread the genetic code, you're going to get a lot of things going on. So the initiation complex won't be able to form because if they may not be able to correctly read the start codon, which what is the start codon in bacteria?
FMET.
Yep, FMET, that's right. And then they could cause truncated proteins because they could misread the codon as a stop codon, which causes the premature termination. And then obviously just inserting the wrong amino acid, if you get enough of the wrong amino acids inserted in the wrong places, then you'll have a non-functional protein because they'll misfold. And so in a lot of these, they'll have like kind of a main effect that they do, and then they also may do some things on the side as well. So I'm not saying you're wrong about the exit thing. This is just the primary thing that they do, if that makes sense. And then, so they bind irreversibly. So is that going to make them bactericidal or static?
Bactericidal.
Bactericidal. And so these are all going to end in CIN, C-I-N. And the way that, but there's a lot of antibacterials that end in CIN. You have your vancomycin, your daptomycin, and all of your macrolides are going to end in CIN. And you also have your lincosamides that end in CIN, clindamycin, lincomycin. So the way that you remember which ones are your aminoglycosides is there's an acronym, NATS, which I'm sure you all have heard of. And so that spells the first letters, the GNATS. Yes, and out of these listed here, so which one of these, first off, how do we usually administer aminoglycosides?
IV.
IV, so, or IV, so parenterally, yes, IV or IM, but which of these is not going to be administered like the others?
Neomycin.
Neomycin, and how's that one going to be administered?
It's usually topical, but also for bowel prep.
Yes, yes, wow, very good, yes, wonderful. Topical is just the primary one that you have to remember, but bonus points to you. All right, so adverse effect. So these are going to be super, super toxic, and the reason being is because they have a small therapeutic window, which means that the dose that you need to achieve in order to get a therapeutic response is going to be very close to the dose that starts to cause toxicity. So you have a very small range to work with here. And so aminoglycosides are going to be notorious for what two big things?
Ototoxicity and nephrotoxicity.
Correct, correct, correct. So the ototoxicity, let's talk about that first. So is this going to be largely irreversible or reversible?
Irreversible.
Irreversible, right, as opposed to the kidneys, which a lot of times can be reversed. Not always, but a lot of times. And so it's going to accumulate in the inner ear. So I know you haven't had ear anatomy yet, but endolymph, perilymph, those are just the fluids that your hair cells sit in, and also that sit in all the different tubules and sacs that sense proprioception and motion and things like that. Also, in addition to the accumulation, you're going to just have some frank effects on the nerve itself. And what cranial nerve would that be?
8.
8? Yeah, 8. Good. Very good. And so what would be some symptoms of ototoxicity with aminoglycosides?
Vertigo.
Yeah, okay, so vertigo and ataxia, those would be balance issues. Ataxia is when you kind of have this wide stance, kind of like a little toddler who's first learning how to walk. You have this really wide, uncertain kind of stance. So the balance issues would be what we call vestibular issues, which, yes, is a part of ototoxicity. What would be some of the hearing issues of ototoxicity?
Tinnitus.
Yep, tinnitus, so ringing in your ears, and then also just deafness in general. And so there's going to be, oh, did I pull that up? No, I did. Yes, I did. Okay. Yeah, there we go. And then so there's going to be certain people who are going to be at increased risk for having this ototoxicity. And so who are those people going to be?
Is it pregnant women?
Oh, go ahead. Go ahead. Were you saying something? No, not going to admit to. Okay, that's cool. Okay, so so the first thing, so people who are already have trouble hearing, so who already have some sort of impairment, they're going to be at risk. And then people who the elderly are also going to be at increased risk. And then people who are receiving a certain drug. Does anybody know what drug that is?
Diuretics, loop diuretics.
Yes, specifically loop diuretics, yes. So those are your osamide, your furosemide, torsemide, things like that. But particularly, which loop diuretic is going to be the most dangerous to give with this? It's the one that doesn't sound like all the others. Nobody? Ethacrynic acid. Oh, sorry, what? No? Okay.
It's not the right one.
Okay, okay. So loop diuretics, I know y'all probably talked about them really briefly in your nephrology unit in MOS, but so loop diuretics are going to have some baseline ototoxicity with them. A lot of times it's not going to be a problem unless you give them at a really high dose for a really long time. unless you're using ethacrynic acid. Ethacrynic acid has a higher rate of ototoxicity than do the rest of the loop diuretics. So, anyhow, so if you're giving a patient loop diuretics, particularly ethacrynic acid and an aminoglycoside, the ototoxicity there is going to be additive. So that's not something you want to do. And then also the ototoxicity, not yet. The ototoxicity can be precipitated by renal failure because aminoglycosides are going to be excreted how?
The kidney.
By the kidney. Yep. And so and since nephrotoxicity is the second major toxicity of aminoglycosides, as your kidneys start to fail, they're not going to be able to excrete the aminoglycoside like they could previously. So your concentrations are going to jump even higher. And as your concentrations start to jump, then that's when you're going to precipitate the ototoxicity. So a lot of times you'll see the progression of the patient from healthy to the nephrotoxicity and then ototoxicity. All right, so let's talk about the nephrotoxicity part. So you said the ototoxicity was largely irreversible. So the nephrotoxicity by process of elimination is going to be largely what?
Reversible?
Yeah, that wasn't a trick question. Yeah, and so it's going to be due to an accumulation in the renal cortex, and we just talked about how because these are urinary they're excreted by the urinary tract, that that the nephrotoxicity can precipitate the ototoxicity. And do we want to give these in pregnancy? No, we don't. There's kind of like a little stipulation that unless extreme circumstances, so basically if it's like you lose mom and baby or you give these in pregnancy, then you'll take your chances and you'll try to save them. But for the purposes of your test, no in pregnancy. Okay, so what's another toxicity? Not as famous, I guess, as the nephro or ototoxicity, but still not a great thing to have.
Is this the one that like goes with the myasthenia gravis?
Yes, very good. Yep. So neuromuscular paralysis, and obviously neuromuscular paralysis is not a great thing to have ever. But why would it be particularly? Why would we particularly worry about it though? In our patient.
Breathing problems?
Yeah, exactly. They would go into apnea if they lose their respiratory muscles. And so the reason it's not as common as the ototoxicity and nephrotoxicity is because it really doesn't occur unless you're giving it at really high concentrations or unless you have, like you just mentioned, myasthenia gravis, which just quick review, myasthenia gravis, that's an autoimmune disorder. You get antibodies against the acetylcholine receptors on the postsynaptic cell. So that's going to be your muscle cell in this instance. And so it causes down regulation of those receptors, decreased sensitivity, so you get this generalized weakness. And it's exacerbated by things that can either further decrease sensitivity or affect acetylcholine, or things that tire the muscles out. So this would qualify. And so what the aminoglycosides do, they kind of have a double whammy. They decrease how much acetylcholine is being released by the presynaptic cell into the synapse, and they're going to decrease sensitivity by the postsynaptic cell, which in myasthenia gravis is already impaired. So how would we treat this? Well, there's two drugs that we could give to treat a neuromuscular paralysis crisis. Anybody know? So the first one is going to be calcium gluconate or neostigmine. Neostigmine you should have seen before. What is neostigmine? Anybody from Dr. Tenner's lecture? No? Okay, so neostigmine, that's going to be a competitive reversible inhibitor of acetylcholinesterase. So if you block acetylcholinesterase, then you get the acetylcholine gets to hang around in the synapse longer. Normally it's really quickly degraded, so that you can have fine control over muscle movement, but this allows more of it to stay around longer, so that can help. And then calcium gluconate, that one, it works by increasing the acetylcholinesterase release from the nerve terminal, and then it also enhances excitation contraction coupling in the muscle, which basically just means you get more bang for your buck. So there's more cell signaling and cascade and contraction for every unit of stimulation. Okay, and so we already said these are poorly absorbed, so we're going to administer them parenterally. And we already said that the exception was which one?
Neomycin.
Neomycin, yep. That one's given topically because its nephrotoxicity is to the point where it's really unacceptable. And do these penetrate the blood-brain barrier?
No.
Nope, they don't. But what we can do is we can give them intrathecally, which means that we stick this needle into the CNS and we can administer them that way. Generally not something you want to do if you don't have to, though. And so what is the spectrum of activity going to be with aminoglycosides?
Mostly gram-negative aerobic.
Yeah, yep, exactly. The reason being for that, you won't be tested over this, but if it helps you remember aerobes, it's because the transport system there, it requires oxygen. So obviously you won't find that in an aerobe. Okay, so I mentioned this earlier, but so aminoglycosides, they were once really widely used. My mom has been a nurse for a really long time, and when I was practice giving this presentation to her, and she was like, "Oh my gosh, I've hung so many aminoglycoside IV bags in my life." But now you don't really see them much anymore because they're so toxic, and we have other things that can take care of the job with less toxicity. You will still use them in a few instances. There's kind of three major areas where you would see this. What's one of the big things that you would use these for? We've talked about it a little bit yesterday.
Pseudomonas.
So you can use them in treating so yes, you're right. You can use them in treating resistant, life-threatening gram-negative infections, which Pseudomonas, being so resistant, certainly qualifies for that category. Yes, you're right. And it's not the bullet I'm going to pull up next, though. What else can we use them for in treating?
Endocarditis.
Endocarditis. And what would we combine them with to treat that?
Beta-lactams.
Yes, beta-lactams or
Vancomycin.
Vancomycin. Yes, exactly. Oh, why is it not coming up for me? Yes, and then yes, and then also streptomycin. Y'all covered this last unit. What else can streptomycin treat?
It's a second-line drug for tuberculosis.
Exactly. Okay, and then you just mentioned before that, Michael, about how they can be used to treat serious life-threatening, resistant gram-negative infections. And you also mentioned that you can combine them with, that you can use them to treat Pseudomonas. And do y'all remember which cephalosporin you would use to treat Pseudomonas?
5th generation, the ceftarline. Oh, sorry, no, that's MRSA. It would be the 3rd and the 4th generation.
Yes, particularly the 3rd generation. Do y'all remember specifically which drug was developed for Pseudomonas treatment in the 3rd generation?
Is it ceftazidime?
It is. Very good. Very good. Oh, oops, I didn't even bring that up. I already had it up. Sorry. Yes, it is. And then let's see. And then neomycin, you already told us earlier, the topical you can use as a bowel prep. Why can you use it as a bowel prep? Because these are really, if it has so much nephrotoxicity, why could we use it as a bowel prep?
It's not absorbed.
Yeah, exactly. Very good. And then hepatic encephalopathy, you won't be tested on that part. You won't really learn about that till SD1. What hepatic encephalopathy is when you're your liver, it usually cirrhotic, it starts failing, so it can't process and handle ammonia like it should. And so ammonia starts building up. And as ammonia builds up, particularly it'll start affecting your brain, and you'll progress to this kind of comatose situation. And so the reason that neomycin works for that is it kills off a bunch of the ammonia in your gut that generate, a bunch of the bacteria in your gut that generate ammonia. So you kind of quit adding to the already accumulating ammonia there. Lactulose would be the first string drug for that. So, all right, macrolides. So macrolides are going to act on which subunit?
50S.
50?
Yes, exactly, 50S. And they're gonna bind reversibly. I mean, remember, aminoglycosides bound irreversibly, which made them bactericidal. And so what step are macrolides going to inhibit?
Is it translocation?
It is, translocation step. And are these gonna be cidal or static?
Static.
Static, yep. And so all of your macrolides are going to end in thromycin, which makes it a bit easier to remember. Except for fidaxomicin, that one's special. What else is special about fidaxomicin besides the fact that it doesn't follow the naming rules?
It's tidal.
Oh, go ahead. Yes, it's cidal. Very good. So all your macrolides are static, except for fidaxomicin doesn't follow the macrolide rule, and it is cidal. And what is it? It's designed to treat one bug pretty much. And what bug is what does it treat?
C. diff.
C. diff. Very good. All right. So, and all of them can be given orally. Adverse effects. So with this one, remember yesterday I said normally you don't need to worry about diarrhea, nausea, vomiting, those sort of things. But for these, it is important to remember because one of these can actually be used as a laxative. Does anybody know which one?
Erythromycin?
Yeah, very good. It'll be used in levels below what's needed to achieve an antibacterial effect. And you use it in patients who have certain GI conditions. Yeah, so it's important for macrolides to remember the epigastric distress. I had a question about that on my test last year. So clarithromycin, that has metallic taste, that's not super important. What is another adverse effect that these can cause, particularly erythromycin?
Torsades.
Come again?
The ventricular fibrillation.
Oh, yes, you said torsades. Yes. So QT prolongation, that is correct. Not my next slide though. How are these going to be excreted?
In the bile?
Yeah, so they're excreted by the liver. So what could be a potential adverse effect there if they're excreted by the liver?
Jaundice. Hepatitis.
Jaundice, yep. And that's particularly going to be with one of the forms of erythromycin. And then, yes, you told us about that these are arrhythmogenic. And by the way, what's the other major class of drugs that's arrhythmogenic?
Fluoroquinolones.
Yep, your quinolones. And also what one drug that we talked about yesterday is also arrhythmogenic. It was part of your lipoglycopeptides.
The telavancin.
Telavancin. Yep, good. Very good. Okay. Do these penetrate the blood-brain barrier?
No.
Nope, they sure don't. And so what is going to be something that you have to worry about with especially erythromycin and clarithromycin?
Cytochrome P450 inhibition.
Yep. So you're going to have to worry about the things like warfarin, those types of things. If on the test, if they want you to think about that, they're usually going to use warfarin as an example if that's what they want you to be thinking. Erythromycin doesn't cause that problem because it's not metabolized by those enzymes in the liver. We already said they were excreted by the liver, which is why they can potentially cause that jaundice. One of them, though, clarithromycin, is also excreted by the kidney some. So they probably won't test you on that one. They would use, if they want something having to do with liver excretion, they would test you over either erythro or azithromycin. And so just to briefly talk about each one a little bit, because their spectrums of activity do differ a teeny tiny bit. Erythromycin, what is this going to be primarily active against?
Chlamydia?
You're right. It can be used to treat that. Yes. So intracellular is going to be a big thing. So you're right. But even broader than that, what is it going to be? Gram positive or gram negative?
Gram negative?
I kind of set you up for that, didn't I? Because you just talked about chlamydia. So these are primarily going to be gram positive. The reason that they can treat the chlamydia and whatnot is going to be because they are active against intracellular bacteria. And so remember, tetracyclines were able to target some intracellular bacteria, the chlamydia and the rickettsia, which apparently I don't know my species for. But the erythromycin, they're kind of unique in the world of the protein synthesis inhibitors because they're going to be active against gram positives and intracellular. And so chlamydia would be an example of an intracellular bacteria. What are some other examples of intracellular bacteria that erythromycin or macrolides in general could be used to treat?
Rickettsia?
Oh, sorry, go ahead.
Rickettsia?
So, yes, they're not really, you would probably use a tetracycline before you'd use a macrolide for most rickettsia, but rickettsia is an intracellular. But so the one that I'm thinking of, though, particularly for erythromycin, clarithromycin, it causes a pneumonia, and you see it very often in COPD patients. It travels in water, or it's in water supplies.
Legionella?
Yep. Yeah, and so Legionella, you're one of the kind of the key words for that is you see it a lot of times in COPD patients, but and elderly and slightly immunosuppressed type people, but COPD is a big one. And then also ureaplasma, that's kind of like a subset of mycoplasma that causes an infection of the urinary tract. It is sexually transmitted, but it's not really listed as an STD. But anyways, that one's intracellular and can be treated by this also. And these are also unique to in the world of protein synthesis inhibitors because they're not going to be active against a lot of gram-negative aerobes. All right, clarithromycin is kind of a carbon copy of erythromycin. It's going to be active against a lot of the things that erythromycin is active against. So that means the intracellular organisms part, chlamydia, legionella, ureaplasma are really the three to remember for those. Also, clarithromycin, though, can be active against Haemophilus. Azithromycin is going to be a little bit different from the clarithro and erythromycin. So clarithro and erythromycin, we said, have a lot of gram-positive coverage, but azithromycin is not going to have as much of that. Oh no, I didn't mean to bring that up a second. I didn't know they came up together. Oops. Okay, so so what is the going to be the primary indication for azithromycin?
Respiratory infections?
Huh?
Respiratory infections?
Yeah, yeah, respiratory infections. And the way I remember this, so azithromycin is the one that, you know, President Trump and them, they're saying, and the doctors are saying might be a potential treatment for coronavirus, which, you know, obviously has a different, it's not due to its antibacterial effects. But anyways, maybe that'll help you remember that azithromycin is going to be one of the drugs that you would commonly use for respiratory infections. It is the drug of choice, although it's not always used as the drug of choice for what infection? Michael mentioned it earlier.
Chlamydia?
Chlamydia. Yep. So it's considered to be the drug of choice for chlamydia, or one of the drugs of choice for chlamydia, but a lot of times it's not going to be always used as that. And then so also we talked about trachoma earlier, and how every baby is going to be prophylaxed for trachoma regardless of whether the mom you know, has risk factors or infection or whatever. What exactly, somebody tell me, so what exactly, because I had gotten a few questions yesterday when I was a tutor on call about what exactly like trachoma is. So does anybody know exactly, can they like briefly describe what trachoma is exactly? It's actually an infection of what? Is it an infection of the cornea, or is it more so an infection of the eyelid?
The eyelid.
The eyelid, yeah. So that inner surface of the eyelid gets infected, and you get this inflamed tissue, this granulation tissue, and it's kind of rough. And so what happens is every time the baby blinks, it's going to be scratching across the cornea. And what'll happen is then the cornea responds by kind of developing this big scar kind of like tissue, and this pseudomembrane type thing. And so the scar tissue is going to block, you're not going to be able to see through it because it's going to be dense and opaque. So you can use azithromycin to prophylax infants. What's another thing that's commonly used to prophylax trachoma in infants? Nobody? So silver nitrate is another thing we can use. And then what is another antibiotic that we can use? We haven't covered it yet. It's an antimetabolite. So sulfa drugs, some sulfa drugs can also be used. I think it's sulfacetamide maybe, but some sulfa drugs can also be used to prophylax trachoma. Okay. All right, and then fidaxomicin, the last one, we already said that it was specifically designed to treat what?
C. diff.
C. diff, yep. And we said that it's unique because it's bactericidal, whereas all of the other macrolides are bacteriostatic. And it's actually only active against the Clostridia genus. Sorry, I meant to underline that, not mark it out. And so why would that be important, that it has such a narrow spectrum? Why would that be a good thing?
It protects the normal flora.
Yeah, exactly. So it's more of a targeted silver bullet type thing, and you're not blasting everything around it. Yep. All right, so just to kind of summarize when we would want to use macrolides and some of the drug of choices here, because remember I said drug of choices are going to be really important for your test. So macrolides can be used because they have gram-positive coverage and really good gram-positive coverage. Which one has kind of iffy gram-positive coverage?
Azithromycin.
Azithromycin, yeah. So because they have pretty good gram-positive coverage, we can use them as an alternative to penicillin if needed. They're going to be the drug of choice for several types of pneumonia. What types of pneumonia are those?
Legionella and mycoplasma.
Yep, exactly. So mycoplasma, that causes one of those atypical walking pneumonia scenarios, and then Legionnaires, yes. And then they can also be used to treat ureaplasma. And we said that they're one of the preferred treatments. Azithromycin is technically one of the drugs of choice for chlamydia, although it's not always used. What other drug could we use for chlamydia? What would be another one that would be good to use?
Doxycycline.
We could, yes, we could use one of our tetracyclines. And what would be another one that we could use? We haven't covered it yet. We use a quinolone if we wanted to. But we'll talk about that later. Okay, and then also, so M. avium complex. So you're actually going to, who do you see an M. avium complex infection in?
The HIV patients?
Yeah, your HIV patients. Specifically, does anybody know what cell count?
Under 50?
50.
Yeah, very good. So, and I don't know if y'all have talked about this yet, or if you'll talk about this when you talk about HIV in the viruses unit, but so you'll actually, as soon as your patient hits a cell count of 50, you'll just go ahead and start prophylaxing them with azithromycin because they're so likely to get this M. avium complex, and it can be so hard to treat once they do get it. So, all right, chloramphenicol. The rest of these will be a little bit quicker than those because, anyways. So chloramphenicol, this is that really dirty drug that you don't want to give really unless you have a very, very good reason to be giving it. These are going to bind to what subunit?
50S.
Yes.
And what are they going to do?
Inhibit, I think, the peptide bond.
Yes, exactly. Specifically, do you know the name of the ribozyme component?
23S? No.
No, that one's for the macrolides.
Oh, okay.
Peptidyl transferase.
Yeah, the peptidyl transferase, and that's just like an enzyme that's part of the ribosome. So anyhow, but yeah, those are kind of the if they're going to ask about mechanism of action, the peptide part would be good to remember for that question. It also can act in a few other ways, but the big thing that they would test you on is the peptide bond inhibition part. And so we said these are bacteriostatic or bactericidal. No, that was a question. Nobody? So they are either or, depending on what organism we're talking about. They're bactericidal to some, bacteriostatic to others. And so we said, what's one of the big problems with chloramphenicol? What we talked about before we started talking about any of these drugs. What was that?
It can affect our mitochondria.
Mitochondria.
Yeah, exactly. They attack that mitochondrial ribosome, and so a big result of that. Can you all still hear me? It says that my internet connection is not okay. Cool. All right. So a big result of that is going to be bone marrow suppression. So what would be the result of bone marrow suppression? What would be the big thing there?
Aplastic anemia.
Yeah, so anemias. So there's actually 3 types of anemias that you can get from chloramphenicol. So one of them, yes, is the aplastic anemia. And so is that one going to be reversible or irreversible?
Irreversible.
Irreversible. So then we have if we have an irreversible anemia, we probably also have a what kind of anemia?
A reversible one.
A reversible, yeah, there we go. And so that one's going to be dose related. So you're going to see it at higher doses, and if you back off your dose or discontinue the drug, it should go away. The one that's really, really bad is the aplastic anemia that's irreversible. It doesn't happen very often, but when it does, it's really bad. The patient will need a bone marrow transplant. When my mom was in the Army, there was a little boy she was taking care of who had a really bad infection, and he was actually given chloramphenicol and got rid of the infection, but then he actually died from aplastic anemia because of this drug. So that's a sad story. Let's move on. Okay, so what is the 3rd type of anemia that you could get? It's associated with a specific deficiency.
Is it hemolytic anemia?
Hemolytic anemia, and what deficiency am I talking about?
G6PD.
Yep, the G6PD, which is glucose 6-phosphate dehydrogenase. And just a quick refresh, I'm sure all y'all remember what that is, but in case you don't, so back from BCT, so glucose 6-phosphate dehydrogenase is a part of the hexose monophosphate shunt, which takes, that's not associated with glycolysis. It takes glucose, and basically what it does is it generates NADPH from the glucose, and that's important because NADPH is used to keep glutathione functioning properly. And glutathione, what that does is it runs around the cell, scavenging, oxidizing radicals and things that are damaging structures in the cell. and then it goes back and it gets kind of rejuvenated, it gets reduced by NADPH, so it can go back out and grab more damaging species. So people who have a glucose 6-phosphate dehydrogenase are by and large going to function okay normally, because you have some other ways that you can get some NADPH and whatnot. But when they're exposed to some sort of oxidative stress, the generation of damage is going to outpace the body's ability to produce this NADPH for the reduction of glutathione. So chloramphenicol is one of those drugs that can cause oxidative stress. So in a patient who has a G6PD deficiency, that's where that hemolytic anemia could show up. And what population is G6PD going to be more prevalent in? So African Americans, about 1 in 10, actually, they think might have a G6PD deficiency. Okay, so what's another big thing about chloramphenicol? They'll almost certainly test you on this part. On the big
Cause gray baby syndrome.
Gray baby syndrome. And basically what that is, it's a failure to thrive type situation. Your baby will come out and it'll be kind of like a dark gray or blue color because it's not getting enough oxygen. It's not really metabolically, it's not functioning right. It's just not a really good situation. And so what is the cause of this gray baby syndrome? It's a buildup of what?
They lack the UDP glucuronol transferase enzyme.
Exactly. It's a buildup of glucuronide in the liver because when babies are born, particularly premature babies, but also even term babies, when they're born, they have really low levels of glucuronol transferase. And so if you remember back again from BCT, glucuronol transferase, what that does is it conjugates bilirubin that's being carried around in the blood on albumin. It conjugates bilirubin to glucuronide, and it spits it out into the bile so it can be excreted and everything. So if you don't have a functional glucuronol transferase, then you're going to have this buildup of glucuronide in the liver, and that's going to cause all these problems. So for this reason, chloramphenicol, you don't want to give it in pregnancy. You don't want to give it in infancy. Don't want to give it at all, really, if you don't have to. And so what is another problem that chloramphenicol is going to have because it's such a big, broad spectrum, bad, dirty drug?
Super infections.
Yep. So it can be given pretty much any way you want to give it. Does it cross the blood-brain barrier? Yes.
Yes.
Yep. And how is it excreted? Anybody? It's excreted by the kidney. And then, so spectrum of activity. So we already said it's pretty broad spectrum. It hits a lot of things, but where is it primarily going to find its use?
Meningitis.
So that's one of the indications for it, but what type of bacteria does it target that can be usually really hard to target?
Mycoplasma.
Say it again? I couldn't hear you.
Mycoplasma.
You said mycoplasma? You said microplasma? I'm having trouble hearing you for some reason.
Yeah, I have no idea.
So not particularly. You probably want to use a different drug with mycoplasma, but anaerobes are going to be the big thing that it targets, and anaerobes can be kind of hard to treat because they have a lot of intrinsic resistance things going on, but that's where it's going to find a lot of its use when you do decide to give it. So that's just kind of restating what Ray said. You really don't, this is really a big emphasis. You don't want to give this if you don't have to. So almost certainly on a test, when you get those questions about here's a patient, how do you want to treat them? if chloramphenicol is an answer choice, you can almost certainly mark that one out. You really, really don't want to give this drug. And if you do give it, then you want to monitor their blood to look for those 3 different types of anemias that we talked about. Let's see. And then here's a list of some other things. You had mentioned the meningitis, things like that. Those are all things that you could use it for. But again, this is almost certainly not going to be the right answer on a test if it's asking you how you want to treat this patient. Okay, so the rest of these we'll run through really quickly for protein synthesis inhibitors. They're kind of honorable mention. You don't need to know a whole lot about them. You just need to kind of know that they exist, what their major indication is, and what their MOA is, and a few special things about them. So lincosamides, how do these work? Okay, so first off, what subunit are they going to inhibit?
50S.
50S, okay. And so does anybody know the specific mechanism for them? So they're going to act like macrolides do as far as the MOA. How did macrolides act? What was their specific MOA?
They bound the 23S of the 50S subunit.
Right, and so what was their specific, what step did they inhibit?
Translocation.
Translocation, there we go, that's what I was looking for. So these are also going to inhibit translocation. Are these going to be cidal or static?
Static.
Static. And so which drugs, so these are going to be your clindamycin and lincomycin. Those are going to be the ones in this group. What is going to be the major adverse effect of this?
Superinfection.
A superinfection. Yep. With particularly what?
C. diff.
C. diff. Yes. And particularly, it's going to be it's because it's going to be by certain strains that are C. diff resistant, or I mean clindamycin resistant. And how would we treat a C. diff infection?
Oral vancomycin.
We could give, so vancomycin isn't given orally, but it would be given IV. But so vancomycin could be used. What would be the other thing that?
Metronidazole.
Metronidazole, yeah. Metronidazole is the drug of choice for C. diff, and vancomycin is kind of like a second string drug for that. Yep, very good.
Did you talk about a drug a few slides back that was specific targeting C. diff as well?
Oh, I did. What drug was that?
I don't remember.
Oh, that's why you're asking.
Fitamycin?
Huh?
Was it
Yeah,
fitamycin?
fidaxomicin. And what type of drug was that?
Macrolide, right?
A macrolide, yeah, very good. Yep, good job. Yes, very good. Okay, so these are going to be narrow spectrum, and particularly what are they going to be used for?
Anaerobic gram negative.
Yep, anaerobes, very good. And so where would you get an anaerobic infection from, do you figure? Where's a good place to get an anaerobic infection from? Because anaerobic infections probably aren't going to be, sitting around in the community, right? Because they would be killed by the oxygen.
From a spore or hospital?
So you could get it in the hospital. What part of your body has a lot of anaerobes? In fact, what part of your body has the highest concentration of bacteria out of anywhere in your body?
Your GI tract.
GI tract, specifically your colon. So there's a lot of anaerobes there. So you'll see anaerobes in things like where you get some kind of bowel perforation. So that could be due to trauma. That could be due to some kind of inflammatory disease, Crohn's or ulcerative colitis. That could also be aspiration pneumonia. Will a lot of times be caused by anaerobic infections like Streptococcus or Bacteroides. So those types of things. And then it can also act against some gram-positive cocci. Okay, so quinupristin, dalforpristin. is this one going to act?
Say again.
How is quinupristin, dalforpristin? How's that one going to act?
It inhibits the like elongation, like it.
Yep, very good. Inhibits elongation, promotes release. Very good. Bactericidal or static?
Cytal.
Cytal, yep. And it's actually going to have a, even after you discontinue the drug, there's going to be kind of a lasting effect there for a while. So adverse effects. So you can get some inflammation of your vein when you give it, which is why you want to give it in a bigger vein, like a central line, not a peripheral line. That won't be tested. What's another thing? So how are these going to be excreted?
Through the liver, like.
Got it.
Yeah, through the liver. They're going to compete with bile for excretion. So you could get some hyperbilirubinemia. This really isn't clinically significant because there's been no reports of any kind of jaundice or actual liver damage from this. But it can cause like a hyperbilirubinemic state. You can get some joint muscle pain. What other effect is this going to have? Is it going to play well with other drugs?
No.
No, and why is that?
Doesn't it inhibit like some cytochrome?
Yeah, it's going to inhibit some of your P450 enzymes. And so what is this one going to be? What's its indication? What type of bug?
Is it resistant gram-positive?
Mm-hmm. Very good. Very, very good. And you can, this one also, it is safe to administer in pregnancy and babies if you need to. All right, linezolid. So this one, all of these are going to end in zolid. That's how you know it's a linezolid. How is this one going to work?
50S subunit.
Yes, it's going to bind 50S subunit. And what's its specific mechanism of action? It's going to prevent what? Formation of what?
The initiation complex.
Yes, ma'am. Cidal or static? Cidal or static?
Static.
Static, yes. You can give it orally. Adverse effects. What's going to be a big adverse effect of this one? Kind of similar to your chlorphenicol.
Bone marrow.
Thrombocytopenia?
Yep, bone marrow suppression. Somebody said thrombocytopenia. That kind of goes along with the bone marrow suppression, right? Thrombocytes are made in the bone marrow. And then you can get some neuritis. So, and where is this one going to be used?
Resistant gram-positives.
Mm-hmm. Yep, resistant gram-positives. And so remember yesterday we had some drugs that were kind of used as, it said like an alternative to linezolid. Do y'all remember which drugs those were?
Daptomycin.
Daptomycin was one of them. Does anybody remember the other one there?
Is it vancomycin?
Wasn't vancomycin. Vancomycin's more of a systemic type issue. But it was one that's very similar to vancomycin. What class were those? You remember?
Carbapenems?
Nope, not the carbapenems. It was, so which class of drugs are really similar to vancomycin? They even sound a bit like vancomycin.
Lipoglycopeptides?
Yeah, the lipoglycopeptides, all the vancin ones. So yeah, and so with daptomycin and the lipoglycopeptides, those could be used, or well, not so much lipoglycopeptides, those are mostly skin, soft tissue infections. But the daptomycin, we could use it for bacteremia. Can we use linezolid for a bacteremia?
Yes.
So why would you think yes? What would be your rationale there?
I don't know. It's just a
No, it was
guess.
just a 50-50 guess and no one was answering. No, I get it. I appreciate you answering. So it's actually going to be no. And the reason being is because linezolid is a bacteriostatic agent. So bacteremia or sepsis, if you're septic, you probably are going to have, you're going to be really sick, and it's going to be a really disseminated type of problem going on. So you want to use a drug that's cidal if you have a patient who has a bacteremia. Because if it's static, you're probably not going to get the infection cleared. You want to get it cleared, you want to get it cleared quickly, and a lot of times your patient is not going to have much of an immune response to mount because it's going to be so, they're going to be so sick. So you don't want to use a linezolid for bacteremia because it's a bacteriostatic agent. Okay. All right, antimetabolites. There are only 2 of those. And so these are both going to be bacteriostatic when you give them alone, but then when they're together, they're going to be bactericidal, and they're going to have a greater spectrum of activity. You're really never going to see them used in antibiotic treatment by themselves. With the exception of like prophylaxing trachoma and stuff like that, you can see sulfa drugs by themselves. But most of the time when you give these, they're going to be given together. All right. So sulfa drugs, we'll start with those. How do they work? Anybody?
Are they the ones that inhibit folate?
Yes, they are. And so specifically, so both of these drugs actually are going to work on the folate synthesis process. And so how do they specifically inhibit folate?
They block sequential steps and tetrahydrofolate synthesis.
They do. And so which step are the sulfa drugs going to block?
That step?
Huh?
The tetrahydrofolate or synthase, that first step.
Yes. So they're going to be PABA drugs, and they're going to, yes. So in the metabolism of folate, you have your, so humans, we get folate from our diet. That's vitamin B9. We convert it to dihydrofolate, adding 2 hydrogens on, and then we use dihydrofolate reductase to convert it to tetrahydrofolate by adding 2 more hydrogen on there. And so, and then that'll go and be used in the synthesis of certain nucleic acids. But bacteria are not able to get folate from diet. And so what they're going to do, they're going to take PABA and they're going to convert that to dihydrofolate with dihydroteroate synthase. And so since bacteria have it and we don't, we can target that. And so that's what we do. Sulfa drugs are going to look like PABA, and so they're going to competitively inhibit the dihydroteroate synthase. Are these, and so I already said alone, are these static or cidal?
Alone, static.
Yeah, alone they're static. Good. And then together, yes, they would be cidal. And the way you tell which one is a sulfa drug, they're all going to have some kind of sulfa prefix on them. All of them pretty much can be given orally. A few of them have a few other ways that you can administer them. Okay, so adverse effects. So what's an adverse effect of sulfa drugs? What's one of them?
Photosensitivity.
So that would be one of them. Not my next bullet, but you could get some hypersensitivity type stuff, including photosensitivity.
They bind to albumin, so they can cause kernicterus.
They can cause yes, you were correct about they can cause kernicterus. Also not my next bullet, but these are all great things that y'all are mentioning. What else? Thinking about kidneys. What would be something with your kidneys? Anybody?
Nephrotoxicity.
So they are, but specifically it's because what they can do is they can cause crystallization in your urine. So they can precipitate out, form a kidney stone, and then because of the obstruction, then you would get an obstructive or post-renal, right, from MOS, nephrotoxicity. So what are some ways we could prevent the crystalluria from occurring? What are some things you could have your patient do?
Drink more water.
Yeah, drink more water, stay hydrated, so you dilute the concentration, and you can also alkalinize the urine. Normally your urine is acidic, about pH 5.5, and so if you alkalinize it, sulfa drugs are acids, and so in a basic urine, they're going to be ionized, and if they're ionized, they're less likely to come out of solution, right? It's going to primarily be the neutral form that would come out of solution. And so I think Haley mentioned hypersensitivity. So what the part of the sulfur drug that causes the hypersensitivity is going to be the sulfur part, really. So if you're allergic to any other kind of sulfur containing something, or if you're allergic to sulfur outright, you're going to have cross reactivity with those things. Let's see. Okay. What's another a certain type of hypersensitivity that you can have with sulfa drugs? There's a special name for it.
Stevens-Johnson syndrome.
Yes, exactly. And I think it was Haley yesterday had asked a question about how do we differentiate Stevens-Johnson from red man syndrome. And so the way and I mentioned a few things like, well, the location. Redmond syndrome is going to be primarily face, neck, upper, torso, whereas Stevens-Johnson would be full body. I've mentioned that you could also look at what infection the patient is presenting with. Are they presenting with something that would be more likely treated by vancomycin?
Name more right now.
Huh? Oh, I thought somebody said something. Would they more likely be treated? Do they have an infection that would more likely be treated with something like vancomycin? So that would be things like a staph MRSA infection, or do they have something that would more likely be treated with a sulfa drug, some kind of gram-negative infection, more likely? Another way, though, that you could differentiate the two is that Redmond syndrome is primarily just going to be the erythema, just a red, flat rash. You can have some blistering and things, but that's not going to be as common. If you have blistering, if you have a target rash, that's what erythema multiform is. It's kind of this red look. You have kind of like almost like a target. It'll have like a red kind of flat area, and then you'll have a little center kind of either a papule or just like a really dark red center. So it has like a target type rash. So if they talk about some kind of target type rash, that would be the erythema multiform, or if they talk about blistering, or even peeling of the skin, all of those, especially if they're full body, would be more suggestive of Stevens-Johnson versus Redmond syndrome. Because Redmond syndrome usually is just going to be the erythema, the redness. Okay. What is another thing that we could get with sulfa drugs? Another adverse reaction, adverse effect. You would also see it with chloramphenicol.
Is that hemolytic anemia?
Yes, hemolytic anemia, and you would see that with what kind of I'm so sorry. Give me what I think there's someone at the. I'm so sorry. I'll be right back. Okay. I'm so sorry about that. Okay. Yes. Sorry. So sorry. Yes. So, hemoleucopenia, we said we would see that with what kind of deficiency?
G6PD.
Yes, G6PD. Very good. Okay. And then we also have a, what else can we also get? We also would see this with, chloramphenicol. Also, the linazolids would cause this. I think somebody might have said it earlier.
Bone marrow suppression?
Bone marrow suppression, yes, ma'am. But this is reversible, so it's not as bad as, say, the chloramphenicol would be. And specifically, there's going to be a population. What patient population would you be more likely to see the bone marrow suppression in? So AIDS patients, cancer patients because they're probably receiving immunotherapy, so that also has a bone marrow effect, and so it would be additive. But particularly in a normal, healthy person, you wouldn't really see the bone marrow suppression there. And of course, bone marrow suppression would include things like anemia, granulocytopenia, thrombocytopenia, all those things. What's another adverse effect of sulfa drugs? Similar to our cephalosporins.
Is that the alcohol thing?
So yes, you would see that. You are, well, yeah, so not what I was going to pull up just yet. What else would you have thinking about a certain vitamin?
Is it the vitamin K, like decreased vitamin K?
Yeah, the decreased vitamin K synthesis, because vitamin K is produced primarily where we get it from is from our gut flora, and so sulfa drugs are going to kill off a lot of those vitamin K producing bacteria in the gut. So so what would be the result of a vitamin K deficiency?
Get a lot of free bleeding.
Yep, excessive bleeding. Very good. And then so somebody had also mentioned the kernicterus, and that is correct. And why would you get kernicterus with sulfa drugs?
Doesn't it like kick off the has something to do with albumin? It's not saturated anymore.
Exactly. So bilirubin is hydrophobic. So in order to be transported in the blood, it has to be bound to something. And albumin is what it's going to bind to. Albumin is just a blood protein, preserves oncotic pressure, and carries things around. And so because sulfa drugs also bind albumin, they're going to kick it off, and it's going to have to find someplace else to go. And the brain, neural tissue, is very it has its very I guess not fatty tissue, if you will, but it's lipophilic as well. And so so in normal people and grown people, that wouldn't really be a problem because we have the blood-brain barrier there. But in babies, their blood-brain barrier is not fully formed, so they'll get a buildup of vitamin K, of bilirubin in the brain, which can cause permanent mental retardation. So for that reason, you're not going to want to give it to pregnant women, lactating women who are breastfeeding, because it does pass into breast milk, and you don't want to give it to infants either. And because it displaces things on albumin, it can also affect drugs that bind to albumin, particularly warfarin would be the one that they would test you on if they were going to test you there. And then another thing that probably is not as important, And this probably actually won't even be tested, but he mentioned in the slide, so I'll just mention it here as well. It condenses with formaldehyde, which is important because a certain antibiotic, methanamine, which can be used to treat UTI sometimes, that is metabolized in the urine to formaldehyde, and so sulfa drugs could bind to it and cause some crystalluria issues. I don't think he'll test you over that. Sulfa drugs, they are going to be excreted how? Anybody?
The kidney.
Yep, the kidney. And what is their spectrum of activity going to look like? So they're going to have activity with gram positives and gram negatives, but primarily where they're going to find use is in UTIs. And all of these are really going to be sulfa drugs and a DHFR inhibitor together. Let's see. So pneumocystis, where would we see this?
HIV patients.
HIV patients, good. And nocardia, where do we find that?
In the soil, so like
Immunocompromised.
Yeah, it's found in the soil, and yes, we would see it in immunocompromised patients. Particularly, it can cause things like some types of pneumonia. I believe it causes like cavitary pneumonia, and it can cause things like brain abscesses. And what's kind of special about nocardia? What's one of the kind of histologic features of that?
Partial acid fast.
Yes, it's partially acid fast. And what do they describe how it looks under a microscope?
Branching morphology.
Yes, and they also say because to differentiate it from certain other things that have branching morphology, how do they describe it when it's acid fasting?
Fuchsia color?
Huh?
Is it the fuchsia color?
Yeah, that would be the color of the acid fast stain, but it's also, they describe it as a beaded appearance. Okay, so other things that we can use this for, we can use it topically to prevent burn infection. We already said UTIs. No, we already said nocardia. We indicated that this can be used to prophylax trachoma, also to treat trachoma and other chlamydial infections. All right. Okay, so
question.
I'm sorry, what?
I have a question. How can you use it as prophylaxis against trachoma if you can't give it to babies less than 2 months of age?
Good question. So the way you prophylax with it is by eye drops. And I don't know if I mentioned this yesterday or if I was going to mention it today. Maybe I forgot to mention it. But so with the eye is kind of an immune privileged type of organism. And so you can get away with administering some things as eye drops, ophthalmic, I don't know what the adjective, but anyways, you can get away with administering them as eye drops because a lot of times they won't be absorbed systemically. So I think acid or sulfacetamide, I believe, has an ophthalmologic formulation, and that would be how you would prophylax it would be with the eye drops.
Thank you.
Mm-hmm. Yes, ma'am. Okay, so DHFR inhibitors. So mechanism of action, obviously, they inhibit the dihydrofolate reductase enzyme. And so you have different, the primary ones are going to be trimethoprim and methotrexate. Why are we able to give DHFR inhibitors if we have that same enzyme?
Can't you supplement with folic, like a special type of folic acid that's past that step in humans?
You can do that. So that would be leucovorin, and that would be folinic acid, and you can do that. But a lot of people take TMP-SMX. That's the trimethoprim. say UTI infections, ear infections, and they don't have to be supplemented, why is it, why are we able to give it without having problems?
Does it have to do with how it gets into bacterial cells, like you mentioned in the beginning?
That would be a good guess, and it's almost that way. But so the bacterial DHFR looks different from our DHFR, and so trimethoprim and the other DHFR inhibitors that will be used as antibiotics have a much higher affinity for the bacterial form versus our form. The ones that don't, like methotrexate, it's non-selective. It's an equal opportunity binder for humans and bacteria. And that one, because it's non-selective, it's not going to be used as an antibiotic. Methotrexate is primarily going to be used as an antineoplastic agent, which it's kind of outdated now at this point. It can also be used for certain inflammatory diseases, but that's a different mechanism of action. But yes, so trimethoprim is going to be the primary one that's used here, and it has a higher affinity for bacterial versus human DHFR. So talking about trimethoprim specifically, it is going to kind of be a copycat of the sulfa drugs. What would be some adverse effects that you would see here? So you could see some bone marrow suppression, and what type of anemia would you see with this bone marrow suppression?
Megaloblastic.
Yeah, megaloblastic anemia, and that's where you give your leucovorin there, your folinic acid, because we can absorb folinic acid, but bacteria can't, and so that's why that would be the rescue drug. But you're really not going to see marrow suppression unless you give this for a really long time, or if you have a patient who already has some sort of folate deficiency there. Why would we see megaloblastic anemia with this drug?
Because it affects folate synthesis.
Yes, and so folate and tetrahydrofolate is needed for what? For the synthesis of what?
DNA.
Yes, so you get these big cells that aren't able to actually replicate their DNA and divide, but they just keep growing and getting bigger. So that's why you get megaloblastic anemia. What other type of anemia could you see here? So similar to the sulfa drugs and the chloramphenicol, it would be
Hemolytic anemia.
Hemolytic anemia with your G6PD deficiency. You can see some types of hypersensitivity. You can get some inflammation of the tongue, some sores around your mouth. In patients who have the pneumocystis, you could also see some hypersensitivity there. I don't think they would test you over any of these specific like glossitis type issues. And similar to the sulfa drugs, it can increase the concentration of some other drugs as well, like warfarin, phenytoin, stuff like that. Okay, how are these going to be excreted?
Kidney.
And you can get some resistance if you get mutations in the DHFR. Spectrum of activity is going to be also similar to the sulfa drugs. And so what is the most kind of common combination of DHFR and sulfa drugs?
Trimethoprim and
Sulfamethoxazole. Yeah, exactly. And so what do we call that combination when we put them together?
Bactrim.
Bactrim, yes. You also have a couple of other formulations, but Bactrim is going to be the one that you primarily see. And we said they're static alone, but when you use them together, they become cytal. And so why are they used together so commonly?
Because they're synergistic, they block sequential steps.
Exactly. They block two steps, one right after the other in the same pathway. Let's see. Why would you get the decreased toxicity with these drugs here? Why would you get them decreased when you use them together versus alone?
You don't have to use as much of a dosage.
Exactly, yeah. You get a higher effect with a lower dosage, and because you're using a lower dosage, you don't have as much toxicity. You can also, there's some combinations that you'll use in treating toxoplasmosis and malaria, but that'll be next unit, so don't worry about it for this test. All right, so just a summary of uses for TMP SMX. Primarily gram-negative. What is going to be one of the really common places where you might use this?
UTIs.
UTIs, yep. What's another relatively common infection that we might use it for?
Didn't you say nocardia?
We would use it for nocardia, you're right. Not my next bullet though. We would use this for respiratory tract infections, and kind of similar to respiratory tract infections, where are we going to see a lot of gram-negative infections?
In the intestines?
So a lot of enteric bacteria is also gram-negative, but so ear infections are also going to have a lot of gram-negatives. And what specific infection in HIV patients are we going to use this to treat?
Pneumocystis.
Pneumocystis, yep. And actually, I don't know if this is this unit where they talk about it or if it's the viral unit, but you'll actually start prophylaxing your patients below a cell count, below a CD4 count of 200, because this infection is so prominent in HIV patients. And then there's your GI infections that you mentioned, Michael. There's your nocardia that somebody mentioned, and we can also prophylax burns. That would be topical, and also some community-acquired MRSA. So a lot of indications for trimethoprim sulfamethoxazole. All right, last section. I promise one major one, which is going to be the quinolones, and then a couple of honorable mention. Rifampin, I think you probably covered pretty intensively with the previous unit, but we'll just run through it real quick. And then metronidazole, its main use as far as this unit goes is going to be what?
Anaerobes.
Anaerobe, specifically what anaerobe?
C. diff.
C. diff, yeah. You'll find a lot more uses for it in the next unit with protozoa, but for this unit, mainly anaerobe, specifically C. diff. And all these are going to be bactericidal. All right, quinolones. So these are one of the few fully synthetic antibiotics. And how are these going to work?
They inactivate DNA gyrase.
Exactly. They prevent DNA replication by acting on DNA gyrase. And what do we usually call, what's another name for DNA gyrase that we typically use when we're talking about bacteria?
Topoisomerase 2.
Mm-hmm. Topoisomerase. And no, I don't think this will be tested in this depth, but topoisomerase 2 is what you see in gram negatives, and topoisomerase 4 is what you see in gram positives. But as long as you just remember the topoisomerase part, you'll be good for the test. That's why they're selective for bacterial versus human. Let's see. So what does the cell need to be doing actively in order for these to be effective? Replicating, yeah. If they aren't replicating, then if they're not actively trying to replicate their DNA, then you're not going to be using DNA gyrase, and so it won't do any good to inhibit it. And by the way, what does DNA gyrase do? Or topoisomerase, what does that enzyme do for the cell?
Doesn't it have to do with supercoiling?
Yeah, it prevents the supercoiling, that's right. So quinolones are going to be bactericidal, even though they work on the DNA replication part, because when the DNA gets so knotted up and supercoiled, they're kind of not going to be untangleable. And so you're not going to be able to continue to produce mRNA and things like that to synthesize proteins. So it's going to be kind of out of commission. That's why these are bactericidal. And they're pretty easy to remember, with the exception of the first generation, nalidixic acid. You just kind of have to memorize that one. But all of the other ones are going to end in floxacin. So that is helpful in remembering those. And delafloxacin, again, is going to be a special one for several reasons, which we'll talk about. Cipro is probably going to be the one that you see the most clinically, though. Okay, so adverse effects. What is one of the big adverse effects of fluoroquinolones?
Tendon rupture in elderly.
Say again?
Tendon rupture in elderly.
Yes, exactly. So tendon rupture, and they kind of mess with some of your supportive connective tissue just in general. So for that reason, so they will be cautioned for use in the elderly, but it's not absolutely contraindicated. Where would they be absolutely contraindicated, though? What age group?
Children.
Under 18.
Yes, so pregnancy and lactation, and then generally less than 18 years of age, you don't want to give it. Greater than 60 years of age, like you said, they will be more prone to this tendon rupture, but that doesn't necessarily mean that it's contraindicated. If for some reason you can't give another safer drug like a penicillin or something, this would still be something you could potentially give. You just tell them, don't participate in any super intensive activity, physical activity for the next, while you're on this drug. Don't try to lift anything really heavy, that sort of thing. Okay, well, you can also have some central and peripheral neuropathy, so that you could have some tingling with that. You could have some headache, dizziness, that sort of thing. Similar to the aminoglycosides, these are going to be contraindicated in patients who have what? What kind of autoimmune disease?
Myasthenia gravis.
Yes, that is correct. You don't want to give these to those patients. And these can also result in a what kind of superinfection? Anybody? You can get a C. diff superinfection from these. And then what is the other major adverse effect of these drugs?
Torsades, QT.
Yes. Yeah, so prolongation of the QT interval, except for which quinolone?
Is it 4th generation?
The 4th generation, right, the delafloxacin. And again, other drugs that prolong the QT interval, macrolides and televankin. So, and then these are also going to lower the seizure threshold. So what kind of patients would you not want to give these to?
Epileptic patients.
Epileptics, yep. And then, of course, as with almost any drug, you can have some hypersensitivity issues. So in the case of fluoroquinolones, you can have some phototoxicity. The crystal urea is not going to be super common because urine is usually acidic in normal people anyhow, so that shouldn't be much of a problem. All right, so how do we administer these drugs?
Orally.
Yep, that is correct. Most of them you can also give IV if you want to. And so similar to our tetracyclines, these drugs are going to do what that might interfere with absorption?
Chelate.
Yep, they're going to chelate. And so you're not going to have the calcified tissue effects on bone and teeth that the tetracyclines do. These are more of a connective tissue effect, but you will have the issue of actual administration of the drug. So again, you don't want to give them with your iron and zinc supplements. You don't want to give them with your antacids because those have magnesium and aluminum in them. You wouldn't want to give it with Pepto-Bismol because it has the bismuth. And you also, this one, not that this has anything to do with the cations, but with the sucralfate here, you don't want to give it with that either because that'll prevent its absorption. Sucralfate, it's a drug that you give, primarily it treats like peptic ulcer disease and other kind of GI tract ulcerations. It kind of forms a coating over the GI tract. So you can imagine that it would be kind of hard to absorb something if you have a coating over your GI tract. So these drugs are going to be active against intracellular bacteria, which means that they are going to distribute to what type of cell? So macrophages, that's how you get your intracellular bacteria, because macrophages, they go around eating up bacteria. So things that survive intracellular, you can target them by accumulating in macrophages. And so again, we talked about earlier with your macrolides, Legionella, gonorrhea, chlamydia, intracellular things, you're going to be able to treat with a quinolone. These will also distribute to bone. Do these penetrate the CSF?
No.
Nope, except for which one?
Is it the 4th generation?
That would be a good guess because the 4th generation doesn't follow a lot of rules, but it's actually ofloxacin. And the way I remember that is because the O right here, it kind of looks like, well, it's a bad tracing of it, but the O, it kind of looks like a head, so it goes into your head. I don't know if that helps you or not. And how do you excrete these?
Kidney.
By the kidney, yep. And so spectrum of activity with these, what are these primarily going to be active against?
Intracellular bacteria.
They will be active against intracellular, and even more general than that, they're going to be active against aerobes. So aerobes and intracellular bacteria. They won't treat the M. avium complex though. And what would we what are some other things that we could use to treat an M. avium complex? What would be one of the drugs of choice there?
Azithromycin.
Azithromycin. Very good. All right, so uses for these. These are going to be the drug of choice for what bacteria, what gram-positive spore-forming bacteria?
Anthrax.
Yep, anthrax. We can also use these to treat UTIs is going to be a common use for them, respiratory tract infections, GI infections. These have a really wide use. You can use, they're a fairly safe drug, and you can use them for a lot of indications. And you can also use them to treat tuberculosis and other mycobacterium infections, except for M. avium. All right, and then just to quickly go over the few things that delafloxacin is special for. It is special, one, because it doesn't have any what kind of toxicity?
QT prolongation?
Yes, good. It doesn't have any QT prolongation, so it's not arrhythmogenic. In addition to that, so its spectrum of activity will include 3 additional things that the other quinolones don't cover. Does anybody want to take a stab at what those 3 things might be?
MRSA?
MRSA is going to be one of them. Good. What's another one? I said that this next class is something that's kind of hard to treat.
Pseudomonas.
Pseudomonas is hard to treat. Not really going to be something that you would, not really going to be an additional use of delafloxacin though.
Anaerobes?
Anaerobes, good. And then the last one, does anybody know what the last one is? So atypical pathogen. So mycoplasma would be kind of the main one there. Okay, to run through rifampin real quick, why do you think I put rifampin in red? What effect does it have on body fluids?
You get it like an orange tinge.
Yeah, an orangey red tinge. Yep. So how do these, what's the mechanism of action of rifampin?
Prevents mRNA synthesis.
Yeah, it prevents transcription. Yep, so it blocks mRNA synthesis by binding to the DNA-dependent RNA polymerase. Is it cidal or static? Anybody cidal or static?
Static.
It's cidal, actually, bactericidal. And adverse effects, so we can have some hypersensitivity with it. You can have some fever, malaise. After you take the drug, you can have some kind of flu-like symptoms, a little bit sometimes, more so with another one, but anyhow. And then you can have some liver irritation. We talked about the red-orange body fluids. That's actually one of the ways that, because the health department will actually, if you have tuberculosis, they'll actually come to your house every day and make sure you take your medications. And that's one of the ways that they make sure you're taking your medications is they can look at, are you like sweating, peeing, crying, spitting, orange or red. What's another effect, adverse effect that rifampin has, particularly when you're talking about co-administration with other drugs?
It revs up CYP450.
Yep, P450. And what's kind of interesting about it is rifampin is actually metabolized by the same P450 enzymes that it induces. So it slowly decreases its own half-life. So as you take rifampin for a prolonged period of time, you have to continually up your dose because it's going to be metabolized more quickly. How do we administer rifampin? We give it orally. Does it cross the blood-brain barrier? Yeah, it does. It crosses the blood-brain barrier. We're gonna, that's what I said earlier about how because it induces the P450, it shortens its own half-life, so you have to continually up your dose as you take it. How is rifampin gonna be excreted?
Kidney.
So it's kind of tricky because it does turn your urine a different color, so you would think, well, it must be being excreted by the kidney. But it's actually excreted by the liver. But what happens is you have some intrahepatic circulation. It's the same thing that you have happen with bilirubin. So it's excreted initially by the liver, and then you'll reabsorb some of that as it passes through your GI tract. And then that reabsorbed drug will then also be excreted in the urine. So that's why you find it in both places. And then we can have resistance develop if your DNA-dependent RNA polymerase accumulates mutations. All right, so what do we use rifampin for?
Tuberculosis.
Yeah, tuberculosis and other similar type diseases, so leprosy, things like that. Collectively, they're called the extracellular cavitary bacilli. So basically things that are going to be targeted by macrophages and form those granulomas. You can also prophylax certain meningitis infections with these. All right, last one, metronidazole. How does this one work? So this one is going to basically cause oxidative damage to the DNA. And it does so because it's metabolized to its active form by this enzyme here, furoxidin. And so that's important because furoxidin is only found in certain organisms. So only organisms that have furoxidin will be effectively treated by metronidazole. So mainly that's going to be your parasites, which we'll talk about next unit, and C. diff is going to be your other big one. And so is this, if you damage your DNA, is this going to be bactericidal or static?
Yes, is that my Cidal?
Cidal. And so some adverse effects. It has a metallic taste, not super important. What else can it cause? What type of infection? Nobody?
Superinfection?
A superinfection with what? So we can get, an oral candidiasis. I think in the slides, he calls it like a monoliasis or something. Candida used to be called like Monilia or something like a while back. So that's what he's talking about right there, is thrush or candidiasis, the same thing. You can have some neurological toxicity, both peripherally and centrally, so some dizziness, numbness, paresthesia, tingling. Do you want to give this to pregnant women?
No.
Nope. It's teratogenic, and it also has some connective tissue effects. And this one is the other one that's going to have your similar to cephalosporins. It's going to have what kind of effect? Particularly with alcohol.
It blocks acetaldehyde dehydrogenase.
Yes, so we call that a disulfiram-like effect, and you're exactly right. It blocks acetaldehyde dehydrogenase, which is an enzyme that's involved in the metabolism of alcohol, increases hangover effects. Okay, last slide, I promise. So you give this, how do you administer it?
PO.
Yep, orally, and it has a pretty long half-life, 8 to 10 hours. Does it cross the blood-brain barrier?
Yes.
It does. And it also finds its way into a lot of body fluids, which is important because you don't want to give it to lactating women either, as well as pregnant women. How is it excreted?
Kidney?
It's yeah, kidney and liver. It's excreted by a combination of both. So either could be, so if you have a problem with either, that could affect its elimination from the body. And so uses, it's going to be used, it's going to be one of the drug of choice for protozoal infections. Again, that's next unit. For this unit, the important thing is that it's used to treat C. diff, the drug of choice for C. diff. You can also, it's also part of triple therapy, again, now quadruple therapy for H. pylori. And you also said that you can just, in general, treat anaerobic infections below the diaphragm, which are probably going to come from where?
Your GI tract.
The GI tract, the gut. Yep. Alrighty, that is all. I'm sorry, I know I went a little bit over my time this time, but thank you to those of you who stayed with me. I know some of y'all got tired and left, but there's my email address. So again, if y'all have any questions or whatnot, I'm the tutor on call again today. So does anybody have any questions now that they want answered?
Amanda, I saw that you were recording it. Where will it be? Where will you end up posting it?
So I'm not going to post it, but if you would like a copy of it, since y'all came, I will give you a copy of the recording. Just shoot me an email and I'll reply to it with the link. And the only reason is because if I post it to Facebook and whatnot, then in the future, people won't, like for future presentations, people won't want to show up or whatever. So
I gotcha. Thank you.
not trying to be an ass about it.
Yeah, you're fine. I had to step away, so I wanted to just kind of get a recap on what I missed and stuff.
Yeah, of course. Just shoot me an email and I'll reply with the copy of it.
Awesome. Thank you again.
Yeah, no problem. No problem. Anybody else have any questions that they want answered?
I had a question. I think I had read somewhere that C. diff could be treated with oral vancomycin. I don't know why I think that, but I feel like I read it somewhere. So you said no, right? That won't happen?
Yeah, so vancomycin is not absorbed orally, which I guess that would be why.
I think that was the reason why, yeah, because it would like stay in the gut, and that would be the only advantage to using it orally.
Sorry to like interject. You might have seen it on Sketchy, because Sketchy says that it can be treated with oral vancomycin, and he might have mentioned it as well. So because I wrote it in black and not navy, so it might have also come from lecture. I don't think it's the first line treatment, but for some reason, I couldn't explain why, but I think oral vancomycin would be used in that like specific case.
Okay.
Okay, yeah, I mean, it makes sense. In theory, it should. I don't see why it wouldn't work. So, yeah, I'm sorry, I can't confirm or deny it, but
That's okay. That was it.
Work.
Yeah.
I had a question about the third component of the triple therapy for H. pylori. It's the PPI and the metronidazole. What is the component? Because I keep seeing different things everywhere.
Yeah, so the reason you see a lot of different things is because now they have resistance emerging, so they've switched to a quadruple therapy. Usually the third component is going to be a tetracycline of some sort. Generally now what the standard is you give metronidazole, you give a tetracycline, you give either amoxicillin or ampicillin, and then you give your PPI. But they won't on the test ask you to prescribe a treatment like that. I wouldn't imagine for H. pylori. That's more of a second year SD1 type question.
Okay, thank you.
Yeah, you're welcome. Anybody else? Any other questions? No? Okay. So, well, if you think of one, then feel free to text me or email me. If you want of the recording, shoot me an email. And if nobody has anything else, then I guess that is all I have. Sorry I had to step away there for a while. Y'all are so welcome. I'm glad it was helpful. Last thing I want to do is waste y'all's time. So.
Seriously, this was a huge chunk of time for you, so I really appreciate you doing this over 2 whole days. That's really awesome. Thank you.
Oh, you're so welcome. You're so welcome. I'm glad it was helpful. Where's my end button? Oh, there it is.